Hello, everybody. I'm Susan Weiss. I'm a professor of microbiology at the Perelman School of Medicine, and I've been studying coronaviruses for more than 40 years now. And I'm presently co-director of the Penn Center for Research on Coronaviruses and Other Emerging Pathogens, and I'm the moderator for today's town hall. I want to give a special welcome to those of you who are among the more than 1,200 donors who have so generously supported our work since the pandemic began in early 2020. And thanks to you, our researchers, physicians, and care teams have been able to leverage nearly $20 million in resources at this critical time. So some really good developments have happened, and that is the very fast development and rollout of vaccines against COVID-19, and last week's FDA approval of the Pfizer-BioNTech mRNA vaccine created here at Penn initially. And this has created a lot of hope for us and allowed us to some extent to go back to semi-normal life. However, more recently, the pandemic has become difficult to navigate with the emergence of these variants of SARS-CoV-2, which we'll talk about today, and the uneven return of public health measures like masking and social distancing. So today we've gathered together some of our Penn medicine leaders in patient care, in infectious disease and immunology research, to provide an in-depth look at the current science and what it means for you and your families. This virtual town hall will focus on the COVID-19 vaccines, how the SARS-CoV-2 virus has evolved and spread, including the variants, what we're learning about COVID-19 and our immune system's response, and the urgent needs of different patient populations, including children and pregnant women. So I'd like to invite you all to share your questions in the Q&A box, which is on the upper right-hand part of your screen, and also to check out the events check out the event chat for links to useful websites. And I just want to remind you as well, for the most up-to-date information, including masking and visitor guidelines, obtaining a vaccine, and also clinical trials, please visit pennmedicine.org/coronavirus. In addition, there are many video resources, including presentations from the Center's COVID-19 Symposia, and I will mention here too, we're going to have another symposia on November 2nd, and also on Penn Medicine's YouTube channel. And also, I invite you to check out our center's work on Twitter at PennDOV. So let me introduce you to our panelists for today. I'm first going to just introduce all 6 of them, and then we'll go through some questions for each panelist. So now our panelists for today are Dr. P.J. Brennan, who's Chief Medical Officer and Senior Vice President of the University of Pennsylvania Health System, Dr. Susan Coffin, Associate Chief of the Division of Pediatric Infectious Diseases at Children's Hospital, Dr. Jeffrey Morris, Professor and Director of the Division of Biostatistics, Dr. Onyeka Nwankwo, Chair of the Infection Prevention Committee at Pennsylvania Hospital, Dr. Paul Offit, Director of the Vaccine Education Center also at Children's Hospital, and Dr. John Wary, Richard and Barbara Schifrin, President's Distinguished Professor, Chair of the Department of Systems, Pharmacology, and Translational Therapeutics, and Director of the Institute of Immunology, also here at Penn. So thank you all for taking the time to join us. And we'll start with P.J. Brennan. If you could please just briefly describe your role at Penn and your expertise.
Medical officer for Penn Medicine. My background is infectious diseases, and I've been in this role for a number of years. Throughout the course of the pandemic, at a system level, I've coordinated our activities in managing the pandemic and in the development of our vaccine efforts, both within the health system and in the community. I was recently appointed to be one of the inaugural members of the Delaware County Board of Health, Delaware County's first Board of Health, and previously I directed the tuberculosis control program at the City of Philadelphia.
Okay, so let's start off with a kind of general question. So what are the trends in Penn Medicine for COVID infections lately, and are patients getting seriously ill and being hospitalized?
So I'll expand on that a little further than Penn Medicine, Susan, to say that In the Philadelphia region and the counties surrounding Philadelphia, there are very high levels of transmission. However, they're not as high as are being seen in other areas of the country. If you overlay a map of vaccination rates on top of areas of transmission in the United States, you'll see that the levels of highest vaccination uptake correspond to those where there are lower levels of viral transmission. Within the health system, this being the fourth or fifth wave, however you want to count it, we currently have about 115 inpatients across the entire system. Nearly the majority of those are at our hospital in Lancaster County, where there has been a lot of hesitancy about vaccinations. The vast majority of patients that we have admitted in recent months have been unvaccinated. Since January, when vaccination campaigns began, more than 90%, 94% to be precise, of all of our admissions have been among the unvaccinated. Now, that number has been going down as more and more people are vaccinated, and while the vaccines don't provide perfect protection against asymptomatic and milder disease, there are a few more people being admitted with mild disease. But the serious disease, patients going to the ICUs, ending up on ventilators, and deaths are all occurring in unvaccinated individuals.
Okay, so why are we still wearing masks? And this is a bunch of related questions. Do they provide protection, or how much protection? And do plexiglass shields work, and are they extra protective?
Yeah, so masks have been a very fraught issue. It's challenging to study them because of the different types of masks that people wear and the different ways in which they wear them, under their nose, under their chin. Sometimes they're not sized properly and have gaps. But masks have been an effective tool against this infectious disease and many other infectious diseases. The efficacy of the mask really relates to the nature of the material. And so they range from barely 50% efficiency in terms of filtering out viral-sized particles in cloth masks or gaiters, so to speak, ranging up to greater than 95% protection for N95 respirators and 90 to 95% protection for in terms of filtration efficacy for KN95. Surgical masks have about 80% efficacy. So we're still wearing them because we're still trying to prevent the transmission of infection. And masks have been part of a layered set of mitigation efforts since the beginning of the vaccine. So we ought to be incorporating them into other practices as well, chief among them being vaccinations and then screening efforts before attending work at school. So they do provide protection. As far as plexiglass is concerned, plexiglass is probably most helpful in protecting against larger, heavier droplets that are expelled when coughing or speaking, and they tend to travel a very short distance from the source. But we also know that aerosols of smaller, lighter particles can drift around on air currents and are likely to be able to drift over plexiglass barriers. So I think in close contact situations, plexiglass is probably more useful than it is in exposures that are occurring at a greater distance because of the ability of the particles to float around on air currents.
So we really need both, it sounds like.
Yeah.
Okay, this is a little bit different kind of question. So today is the deadline for Penn Medicine's vaccine mandate. Is everyone compliant, and what's been the results of the mandate?
So we announced our mandate on May 19th and have worked very hard since then. It really went into effect immediately. We expected everyone to start to get their shots, those who had not. When we announced it, we were above the 70% mark in terms of the entire workforce. On July 1st, we required all new hires to be vaccinated, and as you said, today is the deadline. We're in the final stages of cleaning up all of our data, but we know that we are at about 99%, very close to that, and we expect that some people will leave the workforce and that others will be terminated for non-compliance. So it has been very effective, and when we finish cleaning up all the data, I think we will have full compliance.
Okay, thank you. We'll go on now to Susan Coffin. Susan, can you tell us a little bit about your role and your expertise, please?
Sure. Nice to be here with everyone. I'm a pediatric infectious disease doctor who's been at CHOP for many years. Prior to this pandemic, I had the obscure specialization in infection control and hospital epidemiology. And all of a sudden, the work that I've done for many years has become in the middle of the spotlight. So in addition to doing that, I also serve as medical advisor at the city health department and help coordinate some community-based responses focused on children to support them and families throughout the pandemic.
Okay, so first question, what do we know about the outcomes of children who are infected with SARS?
Yeah, the good news is that overwhelmingly children do well with this infection. It's kind of a puzzle why that would be. That's not the case with all respiratory viruses. We have a good experience with some of our most common respiratory viruses causing substantially more serious disease in the very young. But this one's different, and I trust that Susan and John will be telling us why as they get further and further into their studies. We know that about 50% of children, if you take all comers, have asymptomatic or very mildly symptomatic disease. And the numbers of children who require even medical care beyond just a test to confirm illness are quite small, and hospitalization, ICU admissions, and deaths are thankfully very, very small. To date, there have been about 400 children who've been reported to the CDC as having died of this or with this infection. While that is unacceptable, it is a much more modest threat to child health than it is a direct threat to child health than it is to adult health.
I can just add that was the mild disease in children was also true for SARS-1 and for MERS, and so it must be some coronavirus
Exactly.
thing.
Yeah.
Yeah, it is curious. Yeah, and even in the mouse models, the older mice get sicker. Okay, so what factors will influence the ability of K-12 schools to remain open for in-person instruction this fall?
Yeah, I mean, this is a great question, and it's one that we still struggle with. Some of the things we observed during last school year were that there were school districts that were able to operate quite successfully despite having relatively high degrees of community transmission in the areas in which they were located. And a number of studies were able to demonstrate that children who attended school or were in hybrid school had lower rates of coronavirus infection than did their peers who were in all virtual learning. And clearly that has a lot to do with behavior and not so much to do with virus. But I think that really the answer to this question about what are the things that will help us be able to keep kids in school are behavior. Compliance on the part of family with having their kids wear masks and wear them well and consistently, making sure that you're screening a child before they go to school each morning, not sending them to school this year, even if they've got just mild sniffles. This is a time to take even that sort of a previously trivial symptom seriously. And then, of course, when and if someone in your family is exposed, making sure that appropriate quarantine measures are being used. I guess the last is if you have teenagers, please get them vaccinated. That's the very best thing that you can do to help the older kids be in school safely and without interruption.
Okay, related question about how can families with unvaccinated children make smart choices about their activities?
Yeah, this is a tough one, and I think we've all wrestled with this. I think, unfortunately, some of the principles that we operated on during the early days of the pandemic come into play here, particularly in our area at this moment when we have high amount of virus circulating, and with this Delta variant and a strain that's particularly transmissible. My guidance to families is primarily to try and really adhere to masking, to really make sure that the people you're inviting into your home are people who are vaccinated, are people who are doing their own symptom screening, and try and keep your social circles, particularly those in which your children are interacting with other children unmasked, quite small. This isn't the time to go to a big birthday party at Chuck E. Cheese.
Thank you, Susan. We'll go on to the next speaker, next panelist, Onyeka Nwanko. Could you give us a little bit of information about your expertise and your role at Penn, please?
Absolutely. So I'm one of the adult infectious disease physicians here at Penn. I also serve as the hospital epidemiologist at Pennsylvania Hospital. So my roles include evaluating and developing treatment plans for patients who are admitted to the hospital with COVID-19. I also work with some of my counterparts at the other hospitals to develop infection control plans to prevent transmission of COVID within the hospital. And as PJ alluded to with our vaccine mandate, one of my roles became providing information through small group sessions and in many, many scenarios, direct one-on-one counseling for employees who had questions or hesitation about the vaccine.
Okay, so your first question. So what is the Delta variant and how is it different from the other virus types?
So this has been in the news extensively, and one thing that's important to note is that all viruses mutate. SARS-CoV-2 mutates about half the rate of influenza and about 1/4 the rate of HIV. But mutation in this virus is not unexpected. The increased reporting of variants comes largely because the infrastructure to do sequencing and identify the emergence and spread of these variants is now in place worldwide. SARS-CoV-2 has gone through a couple of really big changes in the circulating variants. The original wild-type variant was replaced by something called the G strain back in April 2020. We're all familiar with the Alpha variant, which was the prevalent strain in the springtime wave here in the US. The Delta variant has a couple significant differences in how it behaves compared to some of these other variants. It's about 60% more transmissible than the Alpha variant, which gives rise to uncontrolled transmission of the community in the absence of other measures. It also appears to cause more severe disease, about 2 times the odds of hospitalization, intubation, and death compared to previous variants. And we are seeing this in the hospital with younger patients representing a larger proportion of the hospitalized patients and the patients who become ill.
Yeah, I can tell you on a virus molecular biology level, it has some very interesting mutations that would make it actually infect cells better and spread better as well, just on a cell-to-cell basis. So that all kind of makes sense. So does the vaccine work against Delta?
Absolutely, and that is really the first answer. The most important measure of vaccine efficacy is its ability to prevent emergence of severe disease, of hospitalization, of intubation, of ICU level care, and of death. And compared to the previous variants, the Delta variant, the performance of vaccines against the Delta variants is largely unchanged. Its vaccine efficacy against severe disease, hospitalization, and death ranges from 93% and above in various studies. And this is really the critically important message. For asymptomatic infection and mild symptomatic infection, whereas in trials and in previous population estimates for the previous variants, the mRNA vaccines had a vaccine efficacy of around 94%, population level estimates high 80s to 90%. For Delta variant, speaking solely for asymptomatic infection and symptomatic disease, there does appear to be a moderate waning in vaccine efficacy, with most surveys and estimates ranging from 70 to mid-80s%, which is still really excellent. Anthony Fauci early on in the vaccine development process said he would be hopeful to see a vaccine that had around 60% vaccine efficacy. And even with Delta variant, we are above that. These vaccines remain robustly effective.
Yeah, and the mutations in the Delta virus are not things that you would expect to make the vaccine less effective. So that also makes sense. Okay, so one more question on a little bit different direction. Could the vaccine affect someone's pregnancy or fertility?
This is probably the most common question I fielded from employees who were hesitant about getting vaccinated or who had questions. And it's certainly something that really does require a lot of attention because affecting pregnancy is critically important to many people. We have couple different data points for how the vaccine affects pregnancy. One is population-level surveillance from the United Kingdom, published on August 21st, which show absolutely no sign or signal for increases in stillbirths, miscarriages, or other adverse pregnancy effects comparing vaccinated individuals with unvaccinated individuals. In a more controlled sample, there was a study of 171 patients undergoing fertility treatment. This included about 65% of the patients were vaccinated, another 35% had previous natural COVID infection. In terms of uterine implantation of the embryos, in terms of uterine lining thickness, in terms of egg retrieval, and in terms of achievement of pregnancy, there was no change after vaccination or after previous infection compared to what was usually seen in fertility treatments. So this should be really reassuring, and data like this is why the American College of Gynecology recommends that pregnant women and women of childbearing age should be vaccinated.
That is encouraging. Okay, thank you. The next speaker will be Paul Offit, talking about the vaccine rollout. So Paul, could you briefly describe your role and your expertise?
Sure. I am an attending physician in the Division of Infectious Diseases at Children's Hospital of Philadelphia and a professor of pediatrics at Penn. My expertise is in the area of vaccines. I was fortunate enough to be part of a team at Children's Hospital of Philadelphia that developed the rotavirus vaccine, RotaTech. Regarding the pandemic, I'm on Francis Collins' NIH active group, and I'm also a voting member of the FDA Vaccine Advisory Committee.
Oh, that's very impressive. Okay, so Paul, first question. What will it take to get on top of this pandemic?
Right. I think our ticket out of this pandemic is vaccination. It's really frustrating. I mean, you would have thought the hard part was making the vaccine. We just isolated and sequenced the virus in January of last year, and within 11 months using a novel technology, mRNA vaccines, we had 2 large clinical trials showing a remarkable level of efficacy, and now post-license or post-approval, we have a remarkable level of safety. And we've been able to figure out how to mass produce it, mass distribute it, mass administer it, creating a public health system that really didn't exist to mass administer vaccines for adults. And nonetheless, we've hit a wall. There's a solid 25 to 30% of this country that are saying, no thanks, I don't want the vaccine. I'm going to allow this virus to continue to spread and create potentially variants which may become either more contagious or resist vaccine-induced immunity. And what are you going to do about it? And I think that's where the rubber is going to meet the road over the next 6 months or longer, which is compelling to people to vaccinate through mandates. It's really very frustrating because we can get out of this, just vaccinate.
So this is sort of the same part of the same question. So what's your recommendation for how to deal with people that won't get vaccines?
Right. So there are some people for whom I think the approval, meaning the sort of the full approval or licensure by the FDA, mattered. I mean, 3 of 10 people who were surveyed said that mattered. We'll see whether that really is true or whether they're just going to come up with another reason for why they don't want to get the vaccine. And I think that the what do you do then, though? And I think it's going to be, that it's going to be a condition of employment. And I wish the federal government actually would step forward and say just flatly that all federal employees have to be vaccinated, period. If you want to be part of this society, if you want to be a good neighbor and a member of the society, you should be vaccinated. There's no good reason not to get a vaccine, just a lot of bad ones.
Okay, so on the other side, there are a lot of people that are wanting to get booster shots, and as the Biden administration has just recommended, what are your thoughts about whether the general public should be looking for a booster shot at this point?
I think that was an unfortunate announcement by the Biden administration to say that starting at the end of September, that they wanted the general public now to get a 3rd dose of mRNA-containing vaccine. Certainly, for those who are immune compromised, there is a 3-dose recommendation, but for the general public, that didn't exist. So it brings us back to what Anyaka had said, which is, what's the goal of this vaccine? The goal of this vaccine is to prevent serious illness, to prevent the kind of illness that caused you to go to the hospital or the ICU or die. And this vaccine has consistently done that. As you would expect, the vaccine induces excellent memory responses. Memory responses are generally long-lived. So the vaccine seems to be meeting its goal. So why give a 3rd dose? The other reason that people are arguing for a 3rd dose is that what's happened over time is what you would expect. There's been an erosion to some extent in the level of virus-specific neutralizing antibodies, and consequent to that, you've seen somewhat of an erosion in protection against mild or asymptomatic infection. But nonetheless, despite that, in areas that have high vaccine rates, certainly countries with high vaccine rates, you've seen a dramatic reduction in the incidence of illness. So I don't really yet see a compelling desire for need for the third dose. And I think what's most upsetting about this is what the administration did is they bypassed the FDA, they bypassed the CDC, basically marginalizing them. And that's not the way to do this. I mean, this is what we didn't like about the last administration, with hydroxychloroquine or convalescent plasma or Clorox chewables. But I think, what here, obviously the vaccine is of value, but do we really need a third dose? What you'd like to do is identify the problem, show you have a solution to the problem, say that the third dose then gives you a level of protection that is far greater than you had before, and then go to the FDA and have the FDA authorize it, and then go to the CDC and have the CDC recommend it. This has created a lot of angst among people in both the FDA and CDC.
Thank you, Paul. I'm sure there's going to be a lot of questions about the booster. So the next speaker is Jeffrey Morris, and he's going to speak on using data science to understand COVID-19. So, Jeff, could you also briefly describe your role at Penn and your expertise?
Sure, yes. I'm a professor and director of the Division of Biostatistics here at Penn, and I've been a biomedical data scientist for over 20 years. In the Department of Biostatistics, Epidemiology, and Informatics, we're quantitative scientific experts dealing with how to reliably extract reproducible knowledge from biomedical data. We make sure the data are properly interpreted and the level of uncertainty is properly communicated. And since early in the pandemic, I've authored a blog, covid-datascience.com, which I use my skills and perspectives as a biomedical data scientist to evaluate and synthesize the emerging evidence in the pandemic, filtering out bias and debunking misinformation, trying to accessibly communicate the emerging knowledge.
Okay, so for your first question, are vaccines, so this is a question that a lot of people are asking, is are vaccines protecting against infection, or to what extent are they protecting against infection as opposed to reducing symptoms?
Yes, as Paul emphasized, the key benefit of the vaccines is that they strongly protect against severe disease, and that alone makes them crucially important in protecting against disease and death. But there's still extensive data that's clear that the vaccines are protecting against infection and reducing transmission, just not perfectly. So for infection, pre-Delta, the trial results appeared to hold up in the population, reducing symptomatic infections by 90% and asymptomatic by about 80%. And these numbers have come down with Delta and possibly waned some after 4 to 6 months after vaccination, but they're still substantial. Synthesizing the data, we can still see 70 to 80% protection against symptomatic infections and 50 to 60% against all infections. And also, if we look at transmission as well, pre-Delta, we were confident that infections after vaccination would transmit less, since rough estimates of their viral load from PCR tests were considerably lower. Then with Delta, there were some results that showed this estimate of viral load was just as high after vaccination, leading many to believe that breakthroughs were transmitting just as much. However, based on the available data, there's still numerous reasons to believe that infections after vaccination transmit less. The same studies that showed viral loads were the same showed that after vaccination, they declined twice as fast, leading to a shorter time of shedding. Also, there's infectivity studies that suggest a lower percent infectivity, and also after vaccination, there's more asymptomatic infections, and studies have shown that asymptomatic disease tends to spread 4 or 5 times less than symptomatic disease. So I think we shouldn't forget that the vaccines, although not perfect, are still protecting against infection and transmission. And this current Delta surge would be much, much worse if we didn't have vaccines.
I think everything we've heard has made vaccines seem really, really effective and important. So John and you, Paul and you have also touched on this, but is there anything else you'd want to say about whether vaccine efficacy wanes over time or how much it does or whatever?
Sure, yes. Well, there's evidence from Israel and other places that the effectiveness of vaccines in preventing infections may be waning over time. But one thing to keep in mind is it's very difficult statistically to disentangle all these different factors of whether the vaccine is waning from the Delta effect or from other confounding factors, such as the fact that older, sicker people got vaccinated early. So it's difficult to really get a clear answer to that question, but there's some studies that have used careful statistical modeling that try and account for these issues as well as they can with the available data. And a lot of those come out of Israel and other places, and they suggest that the effectiveness may decline against infection by a factor of maybe 2 and 2.5 fold. However, these studies don't suggest the immune protection has completely waned. And as I mentioned, even after this waning, it appears that the vaccines are still preventing somewhere around half of asymptomatic infections and maybe 2/3 of symptomatic infections. And I think importantly, when we look at severe disease, the effectiveness seems to be holding up even stronger. There's much less evidence of waning. The studies I've seen suggest that 80 to 90% of the severe infections that would have occurred without vaccination are being prevented by the vaccines. So I think that's another important factor to keep in mind here.
Thank you. So our sixth and last panelist will be John Wary. He's going to speak about immune responses to COVID-19 vaccines and treatment. So John, could you, like the others, briefly describe your role at Penn and your expertise?
Sure, thanks, Susan. So I'm the chair of the Department of Systems Pharmacology and Translational Therapeutics, and I'm also the director of the Institute for Immunology. And our role in all of this and our work has really been focused on, for many, many years, immune responses to viruses and vaccines. And during the pandemic, we've spent a lot of time and energy building systems to really study the immune response to SARS-CoV-2, and most recently have applied those systems to studying responses to vaccination.
Okay, so for your first question, what do we know about the different immune responses induced by mRNA vaccine and their durability?
Yeah, this is really important. These vaccines are remarkable, first of all. They induce really potent immune responses, and they do so very quickly. The 2-dose mRNA vaccine series gives you 3 major components of the immune system. One, we're all hearing about it, we just talked about it. They induce very high titers of neutralizing and binding antibodies. We've all now become familiar with the role antibodies play in protecting us from infection. But the vaccines also induce populations of memory B cells. So memory B cells are sort of what stands behind these antibody responses. And the memory B cells are there and present and able to mount new responses in the future. And also memory T cells. And the memory T cells are important because they can recognize parts of the virus that don't mutate very readily, at least so far what we've seen. Now, these different components of the vaccine-induced immune response are important because they act together and really give different kinds of immunity. So the antibodies kind of act like a force field. They are intended to prevent the virus from ever getting in, and they do so pretty well when they're present at high levels. So if you have high levels of antibody, you get exposed to virus may get in your nose, but it doesn't actually have the capacity or the opportunity to infect a lot of cells. If the antibody levels go down, though, or a virus escapes those antibody responses, virus comes in your nose and starts infecting cells in your upper respiratory tract. You have now these memory B cells and memory T cells that jump into gear very quickly. They can mount new responses and contain the virus in just a couple of days, reducing disease, preventing spread, preventing hospitalization and death.
Okay, so the next question is something I'm really curious about as well, is how does vaccination compare to immunity from natural infection? And then in turn, how does it compare to infection plus vaccination, or vaccination plus infection?
Yeah, this is a really important question that many people are asking about. So first of all, natural infection confers good protection from reinfection. We've seen this in a number of studies where the protective efficacy in people who are previously infected can be 80 to 85%. They're protected from new infection. What we don't know is how long that protection lasts. What we do know from seasonal coronavirus infections is that protection may wane over time. What's interesting about this is our vaccines only contain a small portion of the virus. So natural immunity may have immune responses to other parts of the virus that aren't contained in the vaccines. So what we know, though, is if you directly compare people who are just infected and have immunity from infection compared to people who are infected and then also got vaccinated, getting a vaccine after you've been infected actually improves that immunity substantially. So you see a reduction in susceptibility to infection. you increase the titers and quality of the most important antibodies that are neutralizing, and you may actually increase the breadth of that neutralization. That is, you have more capacity to be protected from more variants after you get a vaccine plus previous infection.
So a lot of people have asked if they've already had it, should they get vaccinated? And you're saying yes, they should, right?
Absolutely. We see that one dose of vaccine absolutely boosts those immune responses, improves breadth. We don't yet know enough about durability, but may improve durability of some of the antibody responses a little bit as well.
Okay, and then how do different types of patients, for example, cancer patients or patients with immune deficiencies, respond to vaccination?
Yeah, this is very important, and we see in many of our immunosuppressed patients, obviously, a difficulty in making antibodies. And so that's the one thing that we can measure clinically to know whether the vaccines worked. And certainly in cancer patients, especially those with leukemia, lymphoma, in some patients with autoimmunity who get treated with B-cell depleting therapies, there's some concern about their ability to mount immune responses. We're now seeing that about a third of these patients do have antibodies following vaccination. They sometimes are lower than in a healthy person. But what we also see, and what's important to mention, is most of these patients actually do generate a T-cell response following vaccination. And that T-cell response can actually be quite robust. We don't yet have a lot of data about how effective those T-cells are at preventing infection or severe disease, but we do know that they can participate. We do know that in the setting of natural infection, T-cells play a key role in limiting disease severity. So this is really a glass half full kind of story. These patients probably need a booster vaccination to see if we can get antibody levels up a little bit better. There may be settings where we want to think about prophylactic antibody therapy in some high-risk individuals. But the glass isn't completely empty. Most of these patients are making a T-cell response. They are going to have some immune response capability should they get exposed again, and we're hopeful that that may limit disease severity in those settings.
Okay, thank you, John. So now that we've heard from all of our 6 panelists, we're going to take some questions from the Q&A. So why don't the first 2 questions are kind of related, so I'll read them together, and I know that Paul has some opinions about this, and I'm sure other people do as well. But this is from Doug Smith, a faculty member, how would vaccine mandates be implemented, and what is the experience from past mandates? And a related question, vaccine hesitancy isn't a new phenomenon. In the past, how have we dealt with vaccine hesitancy for other injections, blood draw, etc.? So maybe Paul could start with that one.
Yeah, first of all, the vaccine mandates for children have been in place since the 1970s. All 50 states in the United States have vaccine mandates. Now all but 6 have at least some sort of a pop-off, whether it's a philosophical exemption or religious exemption. But mandates work. I mean, what's interesting to me is that look at a state like Mississippi. Mississippi has one of the lowest vaccine rates against COVID for SARS-CoV-2 vaccine. It's in the sort of low to mid 30% range. But the answer to the question, what state in this country has the highest rate of immunization, childhood immunization, it's Mississippi in the high 90% range, because they were one of only 2 states never to have a philosophical or religious exemption, which is to say you can compel people to do the right thing. You shouldn't have to. You'd like to think in a better world, people to avail themselves of good information that would allow them to make good choices, that would put them and their family in the best position possible. But it just doesn't work that way. Sometimes you just have to have rules. It is interesting that a mandate means that you are asked to get a vaccine. If you don't get it, then you will pay some sort of price. I mean, so for example, PJ can talk more about this. At Penn, you're asked to get a vaccine. If you don't get it, you won't be employed there. But you're not compelled to get it, meaning you aren't pinned down and vaccinated against your will. The only time that's ever happened was in Philadelphia in the early 1990s, associated with the measles epidemic, where 2 faith healing groups were the sort of epicenter of a massive measles epidemic. And there we actually had a state Supreme Court ruling that we could actually compel those children to be vaccinated against their parents' will, and we did that. But that's the only example that I know of compulsory vaccination. I mean, compulsory vaccination in the military, but you can choose not to be in the military. But mandates work.
Does anybody else want to? PJ, do you want to say something?
Sure. Susan, in the case of this vaccine, I think it has been essential for us to have a mandate. When we announced our mandate in May, more than 70% of our workforce had been vaccinated. But that was after 6 months of a vaccine campaign, and everybody had the opportunity to do that. It was very clear that the remaining 30% would only get there slowly and perhaps over years. And we just didn't feel that that was appropriate to wait for such a long period of time because of our concerns about the safety of our workforce and of our patients. So, compelling the vaccine in order to work at Penn was essential for us, and it's worked. It has absolutely worked. The consequences were very important in getting people across the finish line. But we gave people a lot of education and a long runway to make their final decision.
Okay, the next question's for Susan Coffin, primarily, I think, from Mrna Lynn. What would you say to parents who say there isn't enough data on the safety of vaccines in teens?
I'll be glad to start, and I definitely will want my buddy Paul Offit to weigh in as well. What I think we can say is that the immune system of a 16 is not very different from that of a 17 or an 18-year-old. And that we know that there's both robust immune responses as well as very effective protection against coronavirus from these vaccines. We know that there were 18 breakthrough cases, or not breakthrough, but 18 cases in the trial that occurred where there were tens of thousands of individuals enrolled. Every single one of those cases was in someone who had not been vaccinated. A teen who had not been vaccinated. So these vaccines work. And similarly, there are not significant side effects. And when you weigh what can happen to a teen who gets coronavirus in terms of loss of school, loss of time from school, ongoing social disconnection, as well as occasionally some pretty serious health consequences, I think the balance is really clear. This is very strongly in favor of vaccinating teens.
Okay, does anybody, Paul, do you want to?
Yeah, just quickly. I mean, Susan made the perfect point. I mean, if you take that 12 to 15-year-old study of 2,360 children that either got a vaccine or got placebo, there were 18 cases of COVID, all in the placebo group. After that trial was released, and there was then a recommendation to vaccinate that age group. I got a number of emails because I'm on the FDA Vaccine Advisory Committee saying, yeah, but 2,300 children is much smaller study than, say, the study that was done in adults, which were 30,000, 40,000 people. Why don't you do a 23,000 person study? To which the response is, in which case then you would probably have 180 children with COVID, all of whom were in or most, if not all, were in the placebo group. So the question is never when do you know everything. You never know everything. The question is when do you know enough to say that this vaccine's benefits likely outweigh its risks, and there are risks. I mean, now we know that myocarditis is a very rare side effect in sort of 1 in 50,000 range for especially young people that get this vaccine. But again, that is also a consequence of natural infection and far more common after natural infection. So again, there's no risk-free choice. It's just choices to take different risks, and your job is to take the least serious risk. I think people tend to think that not getting a vaccine is just doing nothing, but it's not. It's doing something. So, right.
And here's another question primarily for Susan, I think, from Spiridon Bacchus. Do we have any samples or data of long COVID in kids?
Long COVID is a really mysterious syndrome, and I don't even think we know enough to create a very clear definition of it. But there are definitely increasing numbers of reports and people of all ages who experience symptoms that persist after 3 to 4 weeks. And there's a wide variety of symptoms that are reported. Some people describe this brain fog, while others have problems with persistent loss of taste and smell. I think it's only going to be through careful study that we're going to understand what appears to be a relatively uncommon phenomenon after an acute COVID infection.
Okay, so this is a little different kind of question. And this is for really anybody, are there concerns that future variants will evade vaccines entirely? I have some opinion about that as well. I mean, in order to evade the vaccine entirely, and John can speak to this as well, there would have to be enough mutations to evade the entire antibody response and the cell-mediated immune response. So as a basic scientist, to me, it seems it's not very likely that that's going to happen.
Yeah, I agree, Susan. The antibodies generated by the vaccine do a pretty good job covering multiple antigenic sites on the spike protein, as you know. And we also have these T cell responses. There have also been studies that sort of, theoretically predict what would happen if you mutated every residue of the spike protein to any other amino acid, and to ask how much of that would be tolerated by the virus. Actually, very little.
Right.
So there's not a lot of room for the virus to move a whole lot more. We're obviously all very concerned about this, because if that does happen, it's a big problem. And then we have to figure out how to actually, sort of change our immune response to cover that. But I'm a lot less concerned here than for other viruses that are more problematic, like HIV.
Yeah, it's not like HIV where you have a chronic infection and it's easier to select variants that are going to be avoiding the immune response. This is a much more acute infection, so I think that's less. I agree, it's much less likely. Okay, so here's a kind of related question. Given the increased transmissibility of Delta, even among vaccinated individuals, do you believe weekly testing should be mandatory for all students, as we had previously to this summer, for students, faculty, and staff despite vaccination status, in order to ensure community safety? Be for anybody.
I think that should be Susan.
Thanks, Paul. I think that at lower levels of transmission, where we can rely just on our basic epidemiology to know that infection is infrequent, no, there won't be a rule for doing broad, routine, daily or weekly testing of individuals. I think there may be some circumstances where there's very high levels of transmission, where there's required mixing of highly vulnerable individuals with others who have a high likelihood of being infected, perhaps because they're unvaccinated or they've had an exposure, where testing may play a role. But I don't think as a routine phenomenon for an entire year or so. I would imagine it'd be selective to time and to situation.
Anyone else want to? No? Okay, go ahead, sorry.
Corollary, we do pre-procedure testing on the adult side for all patients getting procedures and surgeries here at the hospital. And in that low pre-test probability population of asymptomatic individuals, the number of positive tests we see is truly, truly extraordinarily low. For students, the infrastructure required to do that routine testing for such a low pre-test probability may not be warranted.
Okay, here's a different kind of question. I just lost it. Most of the discussion's been about the mRNA vaccines. How does the J&J fare in efficacy for the Delta and potential need for a booster?
I guess I'll start. So the to date, there's been maybe 13 or 14 million doses of J&J vaccine distributed in the U.S. Say it again. Yeah. So with protection against severe disease is excellent, and so the question is, I think for J&J is my understanding is they've completed a 2-dose trial, and that hopefully those data will be presented to the FDA so that we can look at whether or not there is a significant increase in protection against severe or mild or moderate disease with that second dose. But right now it's a 1-dose vaccine that works well. It induces, excellent memory responses, as distinct from the mRNA vaccines, where you really need that second dose to induce better memory responses. John can comment on that. But so I think here's my guess. I think that because we're going to need to have a highly vaccinated population for years. I mean, remember, we still vaccinate children with a polio vaccine every year in this country, even though we haven't had polio since the 1970s. We do it because polio still exists in Pakistan and Afghanistan. There's 195 countries out there, many of which have never given a single dose of vaccine. We're going to need to have a highly vaccinated population. If I had to guess the way this plays out over time, I would imagine that the mRNA vaccines will settle out as a 3-dose vaccine, and J&J will settle out as a 2-dose vaccine. But that's just a prediction.
And here's a kind of related question, and some of the pre-entered questions. Like, is there some should more senior citizens, and with perhaps waning immunity, should they be getting boosters? I know you guys have suggested it's not really time for boosters yet, but what do you think about as a function of age? Should they get them sooner than other people?
Yeah, so the ACIP is a tricky subject, obviously, because I'm now over 65. I think the term should not be elderly anymore. I think we should just more mature adult. I think would help. But so when the ACIP met on Monday, they talked about what they would do should the FDA actually approve or allow the Pfizer to distribute their vaccine as a 3-dose product. And the sense that I got was that they at most would layer this. In other words, that the initial group would be essentially similar to what happened when the vaccine first rolled out, back in December. That the initial group may be that group over 65 or over 70 and then work their way down. So I think that's probably the way it's heading. We'll know all this by the end of September because this is all going to happen. The FDA is going to meet this month and discuss this, and the CDC will meet right after that. So by the end of September, you will have this information.
Yeah, there are a lot of questions about spacing between doses. Yeah. Sorry, Jeff.
Yes, and data is rolling in from Israel. They already have 2 preprints out showing the effect of the boosting in reducing infection. One suggested it might be helping against severe disease, and it's very early, but they've gone so quickly in boosting their older population that in the next month we should get a great deal of data about whether that seems to be helping against severe disease in that broad group or if it's mainly in the immunocompromised subset of that group.
That'll be really good to have that information. Yeah.
Just a quick comment, Susan. I think this brings up the broader question of who is in need of a booster because of their immune system. And, we know the severely immunocompromised clearly benefit from a 3rd dose. There's good data on that. Then you get into a fairly gray zone of people whose immune system may be a little bit less than a normal healthy adult, but not really at the point of someone, say, who doesn't have B cells. I think we're going to need a lot more trial data, but I think we're going to see from Israel and other places sort of a graded approach to this, as Jeff said. But the point I want to make is we need data on this while we do this. We need to know how much benefit we're getting and whether we're actually boosting immune responses that are relevant so we can decide how to do this over the long term.
Okay, and here's a little bit different. Do we know yet how well the vaccines protect against the development of long COVID? And I guess one of my questions is that do people that develop long COVID, are they usually people that have had severe disease, or always people that have had severe disease, or not necessarily?
Not necessarily.
I'll speak up just because I've been parts of groups discussing this in children. From what we've observed from self-reported individuals who have experienced prolonged symptoms after coronavirus, it is occurring after both mild and severe disease. And it's a bit difficult to tease apart what might be uniquely long COVID amongst people who have severe disease because they often have residual effects from a prolonged hospitalization. But thus far, there's not any clear signal that mild disease is less likely to result in a long COVID syndrome.
But I think the point I was going to make is that if you don't get COVID in the first place, you're not going to get long COVID. So, I mean, I think just...
Excellent point.
So that's the simplest answer to the question.
Huh. Well, here's an interesting question. Why do some wealthy nations like the UK and US have mortality per capita rates so much higher than lower income countries like India? If that's correct, despite access to healthcare and vaccines? Does anyone know if that's true? And yeah.
I looked at Pete.
A lot of those data are confounded by testing availability. And so typically we rely on a positive test to identify a coronavirus-related death. And testing really has been very slow to penetrate many parts of low and middle income countries.
For India, looking specifically at official coronavirus deaths, I think they're around 440,000 or so. But if we look at excess mortality, which is the number of people who died in a particular year compared to the number of people who typically die in a particular year around that time of the year, India's excess mortality is around 4 million people. Certainly not all of those people would be dying of COVID, but that implies that the impact of COVID is much more than the official death tolls.
And by the way, in the U.S., the official COVID death toll and the excess deaths during the pandemic are very close to each other here.
Okay, here's a kind of more, well, people who are fully vaccinated and want to hang out with people who are not part of their regular social group. What are the guidelines here?
Susan, the question is people who want to hang out with their normal social group but are not fully vaccinated?
No, people who are vaccinated and want to hang out with people outside of their normal social group. Is that what's the recommendation?
Well, the safest thing is to hang out with a group that is fully vaccinated. But if there's uncertainty, then they ought to take precautions in terms of masking and social distancing to the extent possible.
Yes, and one thing we're talking a lot about masks right now, but also I think it's important to remember there's other things we can do to decrease risk, like meeting with people outdoors, or if indoors, make sure it's kind of a larger open area with good ventilation. I think sometimes we forget those factors as we, talk more and argue at a societal level about masks.
Okay. So here's kind of two related questions. Should a booster be needed? How would that affect timing for the flu vaccine? And what is the risk of boosters? Even if benefit is minimal, should we be encouraging patients to hold off?
Yeah, my feeling on this is that I would certainly wait till the end of September before I would get a third dose. I mean, you do know that with the second dose, for example, that at least in young people that you had, much more so than with the first dose, you had evidence of myocarditis. And so what happens with the third dose? I mean, there's not a compelling need right now, as near as I can tell, for that third dose. If we're going to get on top of this pandemic, it's not about boosting the vaccinated. It's really about vaccinating the unvaccinated. I mean, that should be the focus right now. So I wouldn't rush to this. I would wait until, and in terms of regarding flu, normally what happens is the CDC will and the FDA will ask for concomitant use studies. So, and there's hundreds and hundreds of concomitant use studies. You can't put a vaccine onto the existing schedule, without proving that your vaccine doesn't interfere with the safety or immunogenicity profile of existing vaccines, and vice versa. We don't have those data really here yet for flu. So what the CDC said initially, which was surprising, was that give it at the same time, because a lot of people may not come back for that other dose, or just vaccinate them while you got them. I think that if people are willing to come back, it would probably be better to separate those vaccines by a couple of weeks, just so that you can have some idea if there's a safety issue, what the vaccine was, which vaccine was the problem. But hopefully we'll generate those data. I know that the companies are pushing for sort of a yearly vaccine. That certainly works for them. I don't quite see the need for that. It's just as John said, I mean, memory generally is what you need for protection against serious disease. As Onyeka said, I mean, we have excellent protection against severe disease in all studies in this country. So you should, if you've gotten 2 doses of vaccine, you should consider yourself protected, because I think we just scared people. I've gotten emails from people saying things like, when I hit the 8-month mark, I'm going to be out of town for a week. Can I wait that week to get my third dose? I mean, those are the emails I'm getting. We've just scared people into thinking they're not protected.
In the early days of the vaccine campaign, the recommendation was to wait at least to not administer the COVID vaccine within a 14-day window on either side of another vaccine, and that recommendation has been dropped, actually. From an operational issue, running 40,000 people through 2 concurrent mandatory vaccine processes is a challenge. So it would certainly be desirable to be able to do it concurrently.
I'm sorry to say it's 5 o'clock, so I think we're going to wrap it up. So I just want to thank all the panelists. You've been really, really great, and also thank the audience for all the questions. We have a ton more questions that we haven't even gotten to. We could go on for another hour. But Paul can't do that, but anyway, so we hope that we've been able to provide some clarity around all these issues, and that the audience is feeling more empowered in going out there and living with this virus. So keep an eye on your inbox. You'll be receiving a follow-up email, which will include more information and also a link to the recording of this event. And remember, you can always find the latest information on pennmedicine.org/coronavirus, or there is also a toll-free hotline at 833-983-1350. So thank you so much for joining us, and everybody should be vaccinated and safe.